have to do rehabilitation till here. These are not a good healthy bone, right? Till the apex, the bone is not good. It's very thin. Until here, we may need to do rehabilitation for creating prosthetic space also. So we need a good rehabilitation. The metal foramen is almost between the second and first molar. Okay. Extraction is easy or difficult?
Easy.
It will be easy because it is ortho. Already the PDL is PDL will be violent. So extraction may be an issue. So since the patient is young and we can give till 7, we can place better how many implants? 8 implants. Okay. So first premolar. The ridge is thin actually. Right? So this is around 4 mm. It's better to use a 3.75 implant. Anyhow, we will be doing alveoplasty. Okay. Buccolingually, it is very narrow, the mandible. Right? We will see the 360 degree. See, no? The mental. So this is the mental foramen exit. Right? After the exit, the anterior incisive canal is coming. Okay. So now we will see the mental foramen first. Okay, so this is the mental foramen. In front of the mental foramen also, the mental foramen is continuing. Can you see here? Now, yeah, okay. So in front of the mental foramen, it is continuing for 3 or 4 mm wide diameter. Beyond that also it continues, but the diameter reduces. Can you see? So here it is a mental foramen, but beyond that also it is continuing. So that is why it is better to use a short implant. If we injure that incisive canal and its content, it may induce bleeding. So bleeding will happen here. And it may heal or it may not heal, and it may, you can see the peri-implantitis, the implant will fail. There will be bone loss around the apex of the implant. Periapical implantitis. Okay. So that is why it is better to select a shorter implant. Even if it is 10 mm, they are happy. Because if you go deeper, we are injuring this heavy blood vessel contents. Intramedullary bleeding will happen. It will put pressure. Because of the pressure, necrosis may happen, and the patient will have pain. Sometimes paresthesia also patient will tell. We may not have damaged the mental foramen or incisive canal, but the patient will tell paresthesia. That is because of this incisive. Since because you have got from here to here, no need to place a longer implant. So a shorter implant is enough. Okay. The more you tilt it distally, the more risk of
Injuring.
Going close or injuring it. Okay. 10 or 11.5 will be fine. The lateral. See, here the bone is very thin here and all. So after extraction, till the apex, you will do rehabilitation. See, these thin bones and these thin bones, see, imagine the tooth has to go from here to here. Retraction, right? This is proclaimed. Definitely this tooth will not survive the mortar. So here also the ridge is thin. Even better to use a 3.5, a short implant, right? Because you will feel the resistance here. This is a letter. So whenever you are placing midline implant, you have to check this view also. So compared to the midline, how are they? So always keep eye on this axial. Okay, here also the bone is not very great. Okay, but okay, it's manageable. See here, there is thick lingual cortex, a thin labial cortex. The implant is getting stability from this cortex and this cortex. Right, that is, in some way it is good actually. So it is getting stability not from this part, from it is sandwiched between the buccal and labial cortex. So another implant will be placed here. This is second premolar, right? Even distal to second premolar only, mental foramen is happening. This is the first premolar. We see here compared to the first premolar on the left side, here the anatomy is much more bad, like a hourglass appearance. Right? What might be the reason? We don't know. Maybe during extraction, the buccal plate might have got fractured. We don't know. Anyhow, we will be doing oculoplasty till here. Right? We will be removing this bone. So from here only we are going to place 10 mm or 1.5 mm, shorter diameter. Less than 4 we can use. So in this view you can see the mental foramen extensions. Let me see. It may be this one, may be the. This is you can only remove this one. And here, if you place a shorter implant, there is this less. Now we are planning for distal mandate. So this is the second premolar. Since we are planning for giving second premolar, we are checking the mesial root. Okay, if you check the mesial root, the root is very much wider buccolingually. So if you place implant, most of the implant is outside the socket. Nothing wrong. But one small trick is if you push it slightly mesially, starting the drilling from the mesial crest, then you are in good form. So this is a small trick. So starting the drilling from this tip, this crest entrance, and drilling should be towards, not towards the socket. Away from the mesial to the socket. Here the thing is, the canal is little closer. See, usually this is the depression, right? The canal will be below the depression, usually, but here it is above. So we should be little extra careful. So a short implant will do and thinner diameter. So when the nerve is closer, better use a thinner diameter. Mm is enough. Or what we will do is we will put it entirely in the interdental bone. That is also a good option. Right? There it is much more favorable also. Here the canal is little bit away. Even if you put the implant straight, we can place a 10 mm implant. This is a safe option. 4 into 10 now. You see, close to lingual border, you can place a longer. 10 mm is more than enough. We are checking the mesial root of 6. The mesial root of 6 is not very much ideal because the root itself is very much wider infection. So we will try the same technique, interdental. This is the interdental bone. Interdental bone. The bone is good, even though it is just above the. And the first one we can place a 10 mm. So the distribution is also good. Now we are going to the left side. Very exactly above the mental foramen. This is the interdental bone, right? Here also we can place implant. 10 mm is enough. And distal root of 6 we check. And there is a periapical infection is there, keratosis. So more than that, if you go to 7 area, distal to the distal root of 6, here the bone is good. You can place even a straight implant. That's 10 mm implant will do. See the canal. The width is also good. Sorry, implant. So upper we have planned for a bar, right? The sinus is expanded till the 6 and 5 and 4 and it comes till the distal aspect of the canine. Here also, right? Even in 4 region, the sinus floor is going very low. So 6 no bone, 7 no bone. So can we place a good implant in 5 axially? No. Can you place a good implant axially in the 4? No. Okay. Because we have to do malleoplasty also. Because the patient is having gummy smile. See, if we remove this bone, right? Remove this bone, then the remaining available bone is much lesser. So definitely, can you place implant in 6? No. Right? 5 also no. So either you can start from 4 and tilt it mesially or place the implant in the canine. Good pterygoid looks good. So definitely the inter-implant distance will become more. Number of implants which we place becomes less. Because here we cannot place, here we cannot place. So this, if you place, if you use bar, then it becomes long term. It is a very useful. Now we will. The key locations are 2 pterygoids and 2 anteriors close to nasopalatal canal, and 2 more in the canine or premolar. So totally it's a 6, around 6. That's it. If you place the 6 good implants, nothing more is needed. Especially adding pterygoid will give a solid success. So we will check the pterygoid first. We will check the 8. The 8 itself is good actually. Okay. So 8 is slightly buccal. Can you see? This is the palatal curve, this is the buccal curve. So palatal root. Palatal to the palatal root, the bone is good. It's almost 2 mm thick. So if you go along the palatal root also, you are getting some good bone. Till this part you can go, till the lateral wall of the nose, right? You can place it even 15 mm implant. Since the implant is tapering towards the apex, it won't go into the sinus, right? It will be like this. So almost 15 mm or 16 mm implant we can place. This is one option we are keeping an option. Now we will try tilting this distally. Okay, not much change. But now we are leaving the palatal socket and we are going to the 8 oda distal edge. The socket, distal wall, crustal edge here, starting the drilling. Can you see from here? See the sinus beautifully coming here. The molar roots are resorbed, right? So if you go like this, you are getting something like this. This is an SO greater palatal. Okay. So this is a palatal root, but distally. We can place the implant. Here the bone quality is good. You can see the 1300, 200. So slightly tilting in the 8 region. And still more I am tilting. Okay. You are in good bones. Minimum 16 mm implant you can place, 4 to 16. Okay. If you drill more straight, you will enter into the sinus. If you tilt more, you will enter into a weak bone and you may select a shorter implant. So correct angulation is needed, this angulation. Okay. Can you see, by changing the mesodistal angulation, you are entering different zone, you are getting different length. So the key is the mesodistal angulation. Okay, so it looks very critical on the left side, right? What are the challenges? Post-extraction, there may be bleeding, wounds, visibility, suction, gagging, all these things, right? Access, everything complicates the pterygoid. The pterygoid is front, it is easy, but the pterygoid is close to the throat. Now we are checking the right side. This is the 7. 7 looks good actually, right? 7 palatal socket. Palatal socket is a savior many times. See, the bone here is good. Palatally it is thin, but that is okay. We can place it definitely 13 mm. And if you go till the nasal floor, lateral wall of the nasal floor, you can place it 16 mm implant also. You can place. So 4 to 13 or 16 we can place in the palatal socket. Now we will be checking the 8. 8, the root is fused, unfortunately, right? So The more the tooth is fused, the molars, the more it is useless for us. Yeah, you can see. See, no, here these three roots are separated. The more it is separate, the more bone is available in between. See, the more the root is fused, it is one big empty socket after extraction. Where will you place? So now we are planning for classic pterygoid. Okay. You can place it 4 into 16, whatever it is. So more than pterygoid, placing implant in the second molar is good for this situation because the bone is also good and angulation we will get comfortable angulation. So this side we are avoiding pterygoid and we are placing implant in the second one. We can call it the pre-pterygoid. Okay. Now we are checking the first molar. You can see the roots are resolved, right? See the crown length. See the root length. Maybe the patient initially itself she got short root or after ortho. So this is second molar, second premolar. Sinus is close to the apex. Not ideal. Okay. So if you tilt mesially, this part is inside the sinus. So we will start the drilling from the crest, right? Crest of the socket. Now we are into the okay, it looks fine, it is not into the sinus. So how much to tilt, that is the question, because if you tilt very less, you will enter the sinus. If you tilt more, you will interfere with the anterior implant placement. It should be ideal. So how to determine that? So,
Exposing.
yes. So this is the ideal position. Okay, so for that we have to do expose
Flap.
the nasomaxillary buttress area to the nasal area. And this is the lateral margin from here to here. So this is our target. So we'll use the pencil to mark one point here and one point here. Maybe just above the canine, maybe the landmark. Okay, that will be it. Just above the canine. And if you see here, you can see there is a canal coming here. Okay, then this one you see. Can you see? It is coming to this point. So what is the name of it?
EMS.
It is more visible.
Yes.
Huh? That is called canaliculus sinosus. Okay. Here you can see. Can you see here? This is the nasal floor. This is the lateral wall. You can see this one coming and entering the bone. Now we are checking the left side. Left side also. Can you see? Here? It is the canaliculus cyanosus. For some patient it is big. This is the reason patients sometimes experience nose bleeding later. Recently one CLDC patient has a nose bleeding.
Continuous bleeding or intermittent?
Intermittent it will stop. It's not a major. Okay. So from second premolar we are tilting it. Okay. So in this there are two techniques. One is you can go along the palatal floor, or you can start the drilling from the palatal bone and come towards like this. Okay. This is also one technique, but this technique is not useful in this scenario because you will be coming and just hitting this thing, right? And one important thing is here the value is very less, but here it is around 2000. If you stay close to palatal wall and enter the nasal floor, the value is very good, 2000. But if you tilt babyly, it becomes very less. So better tilt it palatally and easily. That's enough. Now we are checking the 1-1 or 1-2 area. The challenge here is we need to do a lot of alveoplasty because the patient is having a lot of gum smile, and we need space. We need space for bar and then teeth also. But not to worry because the patient already has very thin bone, poor quality bone. But if you remove that, the remaining bone will be very less. This is 1-1, right? Yeah, this is 1-1, right? This is between 1-1 and 1-2. Okay. Between 1-1 and 2, but very short implant. Maybe 3.75 into 13. 13 will be enough. Let's see that 360 degree. Now we see that canal. But if the implant becomes close to this implant, so what we can do is, we can start the drilling from 4 and we are not tilting very much, right? We are keeping it up. If you do that, then the implants may not be close to each other. The anterior implant is quite critical because we need bone reduction both to correct proclination and for vertical maxillary axis, right? So if we cut like this, whatever remaining is there we have to use, right? So the anterior nasal spine is very sharp for this patient. What we can do is we can try anterior midline implant. Yeah, midline implant looks promising, right? So if you put implant in the midline, you can engage the midline bone, the femur, okay, and the septum, and place a longer implant also. Can you see here? This, okay. Now we'll check the left side. Six. As usual, 6 is resolved. The 5 is not favorable. Very poor quality. We will try taking the from 5 mesially. Even if you tilt mesially, from 5 you are not getting, right? That means it is the situation is much worse than right side. So from 4 also, if you put straight, you are not getting good bone, right? In the right side, from 4, even if you put straight, you are getting good bone, but here you are not getting good bone. From here you have to tilt so much mesially, then only you are getting good bone. So what we can do is, we will start the drilling from 3. See how the sinus pushes us to start the drilling from more mesially. You can start the drilling from 5 also, sorry, 4 also, but you have to do a transsinus implant. The implant will cross the sinus, then it will engage this 2 or 3 movement. That is also one technique, is it? Transnasal technique. Or you can, there is one more advanced technique, open the flap, elevate the sinus, push the sinus membrane, place bone graft and place this implant. Okay, that is also an option. We are not doing that. We are starting implant from the canine. From the canine we are placing straight. See, from the canine, even if we place straight, the bone is not. The sinus, that means the sinus has expanded till the canine. We will see later. And luckily it has not come later. Right? So from canine we have to tilt slightly mesially. Right? So from the canine, if you tilt the implants slightly mesially, you are in good bone. So from the canine, if you place one implant, you cannot place a implant in 2 and 2 implant. It will be very close. Right here. So this is the canine implant. Can you place implant here? No. So you have only option of middle implant. So it becomes a all on 5. Okay. So it becomes a all on 5. See, the thing is, the inter-implant distance from this implant to this implant is very long. Welding cannot sustain this long. So you need to use a screw retained implant and tighten it. Now what we can do is, we can place some short implant in this forehead. But the problem is, you need to do rehabilitation here. For solving the VME, paid gummies mill and all. Even now it is 8 mm. After rehabilitation it becomes 6 mm, so it's not possible.
So can we do sinus lift and place implant? Keep them as
Yes,
sleeping
yes.
implants, and then
Yes.
after 6 months to
After
be
6
durable
months.
we can use them.
Yes, you can use it. But for 6 months, if it sustains without that implant, then what is the use of that implant? In case if some problem happens, then we can use it.
Since it's only 5 implants,
Yes.
in order to support them.
Or what we can use this parallel socket. Easy. No. Or we can use one implant in the parallel socket of 7. No. No. It is also not ideal. No. or we can do one more implant transinus. But it is also not good, because at least some good bone should be present here, right? We'll check the value of this in a second. It is around 900. So if you place implant like this part will be in the bone, right? After the first year, okay. This entire part will be in the sun. It's only the tip 1 mm into the. But that is a risky implant because the sinus, because the rough surface can infect any moment. Here you can try this 6 palatal socket. You can place a thin implant. For example, you can enter into this thin area. I am checking with 3.5. You can place one implant because the bone here it's good. The nasal floor 3.75 into 13 something. Okay, this looks okay. So now we are making it again into all 6. Okay. The advantage of having a very thin tapered implant, no, you can use this. If it is a non-tapered or a very thick implant, you cannot use in this kind of situation. So the angulations will be more decent angulations will get in this situation because we are not tilting very much, right? More straight. So we can do this. Okay. You cannot
Not
place
conventional compressive or basal. Just for the bar purpose, we are using multiunit.
Yes.
Other than that, we can even place.
Yeah, you can use a single piece also, but inter-implant distance, force distribution, the risk of failure, the bow. No, this. Because each and every position, they are very much critical, right? Apart from this 5 or 6 implant position, we cannot get much more, right?
It says it has basal at the end and compressive at the top. The MU implants. Compressive at the top and basal at the end. Design.
Yes. No. The multiunit basal implant, the multiunit compressive implant, the multiunit is similar to the conventional design. The body is similar to basal. நீங்க என்ன சொல்றீங்க?
எண்டில் வந்து டிஃப்ரெண்ட்டாக இருக்கும் சார். அது வந்து இது த்ரெட்ஸ் வந்து ஸ்டார்டிங்கில் வேறு மாதிரி இருக்கும் சார். மல்டியூனிட்டுக்கு ஸ்டார்டிங்கில் வந்து ஃபுல் ரவுண்டில் இருக்கும் சார் த்ரெட்ஸ். எண்டில் வரும்போது இப்படி ஒரு கட் மாதிரி வரும் சார்.
Yes. Self-tapping. That is self-tapping zero. It is nothing related with basal or ME, whatever it is. The implant design is for ME implants. They have incorporated that self-tapping design. Okay, sure. So if this is implant, this is the regular threads. So there is one small slot is going like this. Okay, that is because why this slot is when the implant is going through the bone, the remaining bone particles, they have got space. In this space they can accommodate, so it will go easily. Okay, so it will easily move further because whatever bone debris or excess bone, they won't get crushed and they won't stop the implant. They will come here and they allow smooth insertion. So this is a self-tapping design.
And then you said patient has gummy smile, no, sir. But since patient has the upper incisors are very much down, that's why she has gummy smile, no, sir.
Yes.
But when we are giving the prosthesis, we will somehow raise the upper.
We have to push the incisor tip
length.
above. For that we need space, no?
Okay.
We need space. If you don't do alveoplasty, they will stop us from giving a normal sized incisor.
Similar. In lower, in panoramic view, the implants were placed one above, one below, and also.
Yeah, that is okay because after alveoplasty, here there is no alveoplasty. So it is kept on different level. If we know what exactly how much alveoplasty we are going to do, we can place implant.
In lower, sir.
Yeah, that's what. See, one implant is above, one implant is below. So that don't worry during planning. That is only tentative only. That is not exact. Because how much alveoplasty we are going to do, we don't know in this case. During surgery, we will do alveoplasty and we will place the all implants at the level of bone or just below the bone. I understand. This one, no? This one, this level.
Because
So we don't have to worry about it. Because this is not exact line. Okay.
because already the bone is very less over there in the posterior region. So when you do all here, we are going to do alveoplasty until the upper extension. If you are going to level the bone
So
in
there
the
will be
same
some
level, then
disproportion.
it will,
Yes, yes. So anteriorly the process will be FP3. As it goes distally, it will become FP2 or even FP1 also. It won't be like everywhere the same space available, but it will be a even one. It will be a neat one. Gradually, it will start as FP1, it will become FP2, anteriorly it will become FP3, then it will become FP2, and in the molar region, only molar they will be. Have you seen the one in the molar region? The space will be very less, but anteriorly. So whether it is a FP1 or FP2, FP3 processes, it is all three mixed process. See, many doctors they do without any alveoplasty. So the process will be more uneven, like this zigzag. Okay.